your first question is, am I going to die if I don't take these antibiotics? And if their answer, if the caregiver's answer is no, you ain't going to die, then you might hold off on the antibiotics. If their answer is, yeah, you're going to die if you don't take these antibiotics, okay, take the antibiotics. Talk to me. They all have me on speed dial because there are better and worse antibiotics, by the way. Not all antibiotics are created equal in terms of biome disruptive risks, right? I'll throw out arguably the worst class on the planet today is what we call the quinolones.
We recently had Dr. Alex Ford on the podcast. He's at Leeds University. He published a fairly seminal meta-analysis in The Lancet on low-dose amitriptyline. And he really sort of opened my mind a little bit more to the utility of a potential low-dose antidepressant. Given that IBS is being reclassified as a disordered gut-brain interaction, and I think there's a really important brain component. And to your earlier comment, I see stress, especially when people are concerned about maybe a c.diff test that was inaccurate, and that's stressing them out now, and FODMAPs, and maybe they've been too restrictive, and that has psychosocial implications. And I don't mean for our audience to sound like a broken record, because I always make this remark, but mindset, stress, things like exercise and time in nature that can be helpful for buffering stress, all I feel have a pretty major time and place. Have you done much, though, with amitriptyline itself, and do you like it?
TGBI, disorders of gut-brain interaction, absolutely right. And this connotation that we have this nervous system in our gut as well that's highly interpolated with our central nervous system and our gut nervous system, and they get jangly, and for sure they get unhappy. I'm a giant fan of low dose tricyclics, actually, and amitriptyline or nortriptyline have both been described. We use them in super low doses compared to sort of their historical antidepressant doses, which were 100 milligrams a day. I start at 10 or 20. I don't know what Dr. Ford said, but I think in my world we typically start with a low dose. We start pre-bedtime because they can be a little sedating, and it's actually helpful if you're not a good fall asleeper at night, especially in the last few years where we all kind of stare at the ceiling, catastrophizing. A little low dose TCA pre-bedtime is actually nice. Trivial side effects, sometimes constipation, a little dry mouth, but no, I'm glad you brought it up. I think on the risk benefit, cost benefit, dollar, they cost nothing. They've been around for 70 years. They've been around for forever. I'm not, again, you do have to have a conversation. It's a very important lead in, though, right? Because you can't just say, here's an antidepressant. You have to have it's important to have that 5-minute conversation that you said very well a minute ago, which is how these two things are, and that I'm not giving this to you because I think it's in your head. I'm giving this to you because I believe it's right. Right. But I'm a giant fan. I think it's a really good, it's probably the first medicine I use because I think it's so low risk and high benefit that the ROI on that is, especially at these low doses that seem to work really well. It's kind of lucky that while it takes 100 or 200 milligrams of amitriptyline to change these neurons, it probably only takes 10 or 20 to change your gut neurons. And that's fortunate.
And by the way, if this has been helpful, please comment and subscribe. This really does help us reach more people who are trying to improve their health, so it is quite deeply appreciated.
What we'd call gut-brain neuromodulators, which are drugs that are conventionally considered as antidepressants, but used at a much lower dose than for the treatment of depression, acting on pain signaling. And I think that's one of the things that came out of our trial that was published in The Lancet recently, which was a definitive trial of amitriptyline for irritable bowel syndrome in primary care, was that we measured both peripheral symptoms, so global IBS symptoms and abdominal pain, but we also measured mood during the trial and during the 6 months of treatment with the amitriptyline versus the placebo. There was an improvement in the peripheral symptoms, so the global IBS symptoms and the abdominal pain, with the amitriptyline over the placebo, but there was no difference in mood scores during that trial at all. So that suggests that although amitriptyline has central effects, or certainly has antidepressant effects, it wasn't acting as an antidepressant. It may be having central effects in the trial, but the central effects weren't an improvement in mood. So I think that's really interesting.
Yeah, I think it's really interesting also, and I really appreciate how you have changed the labels that we may use from, these are antidepressants that are being used for people who are depressed or it's all in your head, toward these are gut-brain neuromodulators, if you will. And I think that reframing is really, hopefully for people, empowering. And the amitriptyline data that you published, I think, is also super interesting in the sense that as we modulate serotonin and norepinephrine, we're seeing this favorable change on these symptoms. And it also has me wondering, since serotonin modulates the immune system, we know it partially functions as a chemoattractant. It'll pull immune cells to sites of inflammation. It can modulate macrophages and monocytes. How do you, or how much do you think that the amitriptyline is, in part of its mechanism of actions, influencing the immune system? And this kind of ties back to your comment on oral tolerance. So if there's this whole, interconnected web of causality, and loss of oral tolerance to food, which is mediated by the immune system, is part of this, do you think part of what these previously called antidepressants, now called sort of gut-brain modulators, are doing is affecting the immune system in a favorable way?
Really, really insightful comment and question. I think, firstly, I'd just point out that it's Doug Drossman who is the sort of godfather of disorders of gut-brain interaction. He was one of the first people to introduce this concept of low-dose antidepressants being gut-brain neuromodulators. So that's not something a term that I've come up with, although I've been involved in work with him to summarise the evidence for the efficacy of these drugs across all disorders of gut-brain interaction. But yes, because tricyclic antidepressants are 60 or 70 years old, they're a drug that, I guess in inverted commas, is quite dirty because they have multiple effects on different receptors. So they have serotonergic effects, they have effects on norepinephrine, antimuscarinic effects, which often lead to the side effects that patients experience, like the dry mouth and the drowsiness. But they also act on histamine, so they have antihistamine effects.
We all know that many antibiotic prescriptions are unnecessary. That's not to say that there aren't necessary antibiotic prescriptions. People's lives are saved every single day with antibiotics. I'm certainly not vilifying antibiotics, but you know as well as I do, roughly half of antibiotic prescriptions in this country are on review. If you take 1,000 consecutive antibiotic prescriptions given in inpatients, outpatients, clinics here, everywhere, it's the same result. We overuse them, right? And you could have a whole session on why we do that and the legal implications of that and all sorts of sides to that. But we overuse antibiotics, and when my patient with C. diff is offered antibiotics, I sort of stamp on their head again. Say no. Your first question is, am I going to die if I don't take these antibiotics? And if their answer, if the caregiver's answer is no, you ain't going to die, then you might hold off on the antibiotics. If their answer is, yeah, you're going to die if you don't take these antibiotics, okay, take the antibiotics. Talk to me. They all have me on speed dial because there are better and worse antibiotics, by the way. Not all antibiotics are created equal in terms of biome disruptive risks, right? I'll throw out arguably the worst class on the planet today is what we call the quinolones, which is ciprofloxacin and levofloxacin and even moxifloxacin, although that's not used very often. But Cipro is one of the dominant antibiotics on the table today. It's often used. It's inexpensive. It's effective. It's a good antibiotic. People actually tolerate it well, but it is the main driver of our C. diff epidemic today. And to the extent that a patient can avoid Cipro or levofloxacin, I ask them to do that. The erythromycins are lower risk. The metronidazole is lower risk. Bactrim or a sulfa class, Bactrim sulfamethoxazole is a lower risk. So there are sort of a spectrum of risk with antibiotics, and that's one thing we can play with. We can try to avoid the bad ones and shift if they need anything, shift them to the minor ones. And then, of course, there's sterilizing their home. That's kind of the big thing. I'd mentioned earlier, and we can elaborate or not, but this bug lives in two forms, right? And the core problem with this bug is not that it's hard to kill. It's fairly easy to kill. It's that it also hides in this spore form. The bug forms a little round hidden spore. And I'm totally anthropomorphizing here, but you remember when you were a little kid, those little pill bugs, they look like tiny little armadillos, and you'd pick them up in your hand and they'd roll up into roly-polies, I think people called them, or pill bugs. I kind of think of C. diff that way. It's obviously much smaller. You can't see it rolling up into a little ball. It's microscopic, but in fact, that's what it does. It has these little tiny spores that leave us and live outside of us and are resistant to most cleaning. They're resistant to, for example, alcohol-based hand sanitizers. So they come out of us and they get on our keyboards and our door handles and our toilet flushers and our what we call our countertops, our touch surfaces. And sadly, these spores can live on these touch surfaces for months, not hours, not days, not even weeks, literally months. These little spores can hang out outside of us and reinfect us or others. And that's one of the core problems here is we're not killing the damn spores. You can give someone Vanco or Fidax or whatever the antibiotic of choice is today, but you're not killing the spores. So sanitizing one's home, and the core answer to that is bleach, right? So it's not alcohol, it is bleach. Bleach is sporicidal. These spores are sensitive to bleach. And if there's any positive outcome of this damn COVID thing, it's that you can now very easily buy giant Clorox bleach wipe tubs. There's now been a giant market in bleach wipes since COVID, and they're easy to find. We've all seen them. They're yellow or red, or Clorox makes a whole line of them. I don't care about brands, but you want a bleach wipe that comes out, and you want to walk around your home and kind of use them as gloves and literally and make it a game with the kids if you want. Put gloves on the kids so they're not getting bleach on their hands, but walk around, and any surface that any human's hands are touching, you bleach the crap out of, and then let all that dry, and maybe 3 days later do a second go round to bleach everything. And that's arguably a really important part of not getting sick again, is kind of sterilizing your home environment. And then the third part, and I'm giving you a longer answer to a shorter question, Mike, I'm sorry, but the third part is, of course, refortifying your biome, and that's we'll elaborate on that, I'm sure. But you got this because you were vulnerable. You got this because you got for either chemo or antibiotics or something that made your biome vulnerable to this opportunistic bug, and we can fortify that. We can try to rebuild up your biome at some level, or try our best to do that anyway, to get you your own resistance, basically. If your biome is healthy, I've been around probably 1,000 C. diff patients at this point now. I have lost count, and so far, knock wood or something, I haven't gotten C. diff, and that's in part because I don't think I've had antibiotics in 20 years, fortunately, and I eat a lot of living foods, and I presumably have a good healthy biome that lets me hang out with these people and probably touch their spores in various ways and not get sick. Well, we got to do that for them, right? We got to get their biome built up again too.
There's non-celiac gluten sensitive. There's FODMAP intolerance. There's lactose intolerance, fructose intolerance, histamine intolerance, and maybe even starchy carb and sugar, malabsorption or intolerance due to, let's say, Candida. One of the things I've been thinking about progressively over time is so many of these, amongst other things, can come down to a lack of the intestinal tract to produce adequate enzymes or metabolize foodstuffs. I mean, FODMAP intolerance, that's been shown to improve with low FODMAP dieting. Histamine intolerance, as the gut heals, it has been demonstrated that DAO enzyme that metabolizes histamine improves, comes back online as the intestinal tract heals. Same thing with lactose intolerance. So I think the real ray of hope here is so many of these food intolerances don't seem to be static, fixed, and forever, but rather, like you were saying before, are downstream to some sort of intestinal damage, inflammation, microbiota imbalance upstream.
Yeah, absolutely. And so many things that, I can think of. I'll start with the enzyme aspect of things, because I would say this is probably the thing where I start with most people who are coming to me with all of these food intolerances. And, I'll ask people, A, are they taking digestive enzymes? And then B, or have they in the past, if I see that they haven't. And, digestive enzymes, there's a lot of different types of digestive enzymes on the market. There are ones that have hydrochloric acid in there. There are ones that just kind of work with pancreatic enzymes. There are ones that have bile acids in there. There are ones that have different enzymes that help us to break down fibers. There's lots of different types of enzymes that are on the market. And so if one person has tried one enzyme, but maybe it was just, it didn't have any hydrochloric acid in there and you needed the hydrochloric acid, or maybe it didn't have any fibrodigestive enzymes and you needed those fibrodigestive enzymes in order to help you to break the food down effectively, we have to really figure out what it is back to the individuality. What does your body need? Where is the hitch in the get along in terms of your body's ability to break that food down? Now, not everybody needs enzymes. Not everybody needs that level of support. So I'll just start there. But most of my clients do. And I've had situations where I work with a lot of mast cell activation syndrome, where just those mast cells are just going off in the gut all the time. And that's kind of what's feeding into the, reactivity that they're experiencing. And just by giving some level of digestive enzyme to them, it calms that mast cell activation. It calms the histamine release. Because now, let's say you weren't digesting or able to break down those fibers, and we have the appropriate enzyme in there for you to help you break those fibers down, we're getting less undigested food in the gut. We're getting less fermentation overall. We're just getting less agitation overall. We're actually able to kind of utilize what we're getting. Remember what HCl does. It's sort of this, that high acid is also sending signals to the rest of the body. It's sending signals to the bile duct to make more bile. Which then sends signal to the pancreas to make more pancreatic enzymes, right? It's kind of sending all of that. And sometimes, if we're, again, I'm going to come back to the dysmotility aspect of things, because most of my clients are constipated. I've got some diarrhea, but the majority just things are not moving, especially in the small intestine, maybe large intestine. I think of, we've got two kind of areas of constipation. There's large intestine and small intestine, right? So somebody can have daily bowel movements and, think I'm not constipated, but if they're bloated and we've got a lot of, reactivity going on higher up in the small intestine, okay, we've got some level of congestion that needs to be opened up. And so I kind of think about what is that hydrochloric acid kind of telling the body, right? So sometimes just adding in the HCl will kind of encourage the body to kind of make more of those things. So when I'm assessing, I am looking at that sense of sometimes the belching, especially after high protein meals, certainly the food that's just kind of hanging out for longer periods of time. They notice that, and I'll assess the diet, like, oh, when you ate the oatmeal in the morning, that felt fine. When you ate the big, chicken whatever, or the beef whatever, or whatever, that's when you really start to notice things kind of hanging out a little bit more, right? So you can also kind of just look at the pattern within the diet to get a sense of whether you need it. Certainly look at the age, particularly, if we're working into our 70s. And then I also look at the stress aspect of things. How many stories have you heard? Like, what was going on at the time that all of this went down? Like 90% of the time, it was like, well, it was really crazy. I was going through a divorce and I was da-da-da. There's just started a new job and I hated my boss and da-da-da. It's like you can kind of, all the things that kind of feed into that. Well, okay, so we also need to, how's life now? And if, I don't know a lot of people who aren't stressed out right now, so it's like, what else do we need to be thinking about from that vagal limbic perspective that could be kind of keeping that, HCl under wraps? Maybe we're not producing enough. So anyway, I do use quite a bit of HCl, for those purposes, just to kind of, I poke around a lot. I'll say that. I like to kind of say well, what happens if we do this? What happens? It's like, oh, I put in the HCl and I either get horrible heartburn or I feel like, yeah, things are kind of moving. Okay, well, we can kind of assess from that. What happens if we do this? So I think we have to step back from well, you're old and stressed, so you need more HCl, and you have to think well, you're of advanced age and you are also stressed. What happens when we do that? What do we see? And then let the body let us know so that we can kind of go that's a piece.
You had mentioned fat malabsorption. So you notice you eat too much fat, maybe you're bloated, maybe you have loose bowels, maybe you have sort of greasy stools that tend to float. So you're thinking here lipase and bile. Are you doing these together? Is there a formula you like? What do you do here?
I might, so if that were the case, I might start with lipase specifically. You can get just straight lipase. You can get ones that are smaller amounts of lipase, and you can get ones that are larger amounts of lipase. So I might just start with the lipase specifically, depending upon the sensitivity of the client. If I see that they're really, like, they don't have good food tolerance, or they taking enzymes or taking any kind of supplement really freaks them out because they're so reactive. This is big in my world, right? I might start with like smaller hundreds, and just kind of see like, A, do you tolerate this? First, always the question, do you tolerate it? And then B, does it do anything for you? And if there's some indication that there's some benefit to it, then okay, can we take another one and see? And then maybe we're seeing that, yeah, the more I do that, it's helpful, but I still need more help. Well, let's maybe go to the larger formula and build that in and see how that works.
What is the data on how children's gut microbiomes impact their future development? And
Yes.
as you mentioned, the immune system, even from, of course, babies, the way that they're birthed, even their experience in utero and the way that they're fed initially, that's going to inform how their gut microbiome develops. And we know that there are certain signatures in their gut microbiomes now that we can see increase the risk for things like eczema or ADHD or autoimmune conditions. And so we're finding these signatures. And when there's disruption to the gut microbiome, so this one study of nearly 800,000 children, it was a military study, that tracked these children from birth to about 4 years of age, and found that those infants who received antibiotics or antacid medications, which are two immediate disruptors to the microbiome, within the first 6 months of life had an increased risk of virtually every single allergic disease, like eczema, asthma, hay fever, anaphylactic food allergies. There's another study in Denmark, which is, they also keep very good records of their population. And so,
Right.
A huge study of mother-infant pairs, and then tracked these infants through time, and found that even just one round of antibiotics at any age could increase the risk of mental health diseases, conditions in that child when they were older by up to 50%. The highest risk was when those antibiotics were received even in utero or under 6 months of age. So again, the early priming.
Earlier, the more detrimental. Yeah.
Yeah, and then the more rounds of antibiotics, the higher the risk. And so any disruption can then have, like we've been saying, this ripple effect on their metabolic system. The rise in type 2 diabetes in children is astonishing. And the rise in pre-diabetes, even in these kids, these teenagers and young kids who look fit, they're exercising, they're on sports teams, they're not overweight. They don't look like the pre-diabetes picture. But when I measure, they're fasting insulin and they're fasting glucose, it's not okay. I mean, their insulin is bumping up against 15, 16, 17.
And Elisa,
right?
quick clarification question there. Do you think this tracks, or is it becoming divorced from caloric intake? Because one of the things I've been noticing in adult populations is at one point there was a direct correlation if you were to draw out caloric intake and, let's say, BMI as sort of a crude gen pop screening. They correlated. But now that caloric intake is going down a little bit, or at least it's kind of leveling off, we're still seeing increases in weight. To my understanding, I'm not an expert here, but there seems to be something divorcing caloric intake from BMI. Are you seeing that same thing in, I don't know how much data, I'm sure there's probably a lot of data looking at this, but have you examined it?
Yeah. I can say in my patients, because my patients are kind of, it's an interesting, more of a, I would say, a quote, select population that comes in who are already a little bit more holistically minded. So I have a very, very small population of, obese and overweight children. But yet I'm seeing this, where these kids, and it's really, I actually haven't tracked their calories, but I don't think it's about the calories. I really think it's about the sugar intake, because now the sugar that is insidiously entering into their diets. I mean, growing up for us, we didn't have Starbucks around every street corner, or boba tea, or, all of these. I mean, we had Coke and soda, right? But it wasn't just this, like, it wasn't a social thing to go out and get a sugary drink. And now, kids and adults, teenagers and adults, I mean, nearly something like 50% of their sugar consumption is as sugar sweetened beverages. And so, and I know so many kids who are going out. I mean, as a social thing, I love the social connection, but they're going out and they're getting, like maybe a 52 grams of sugar mocha chip frappuccino almost every day. And I mean, that is
Because of good marketing, right?
hugely
That's skewing
significant.
sort of how
Yep.
kids think about drinking.
Yeah. And that,
Sadly.
of course, is going to directly alter the organisms that want to stay in your gut. I mean, we know about, candida and yeast over, but it's not just that. I mean, that amount of added sugar is going to directly cause inflammation. I think in some rat studies just can immediately cause signs of colitis. And so, and guess what? You disrupt your gut microbiome, you're going to disrupt your gut brain and gut immune and gut, metabolic connection. And so I think it's really that. In my book, I actually have one entire chapter that I wrote actually for practitioners and parents and kids. That's entirely about what I want parents and practitioners to understand about antibiotics. It's a whole chapter. And then the whole last section, part 4 of the book, is all about the integrative tools that I've learned over the past 20 years to manage the most common acute conditions in kids, and with the goal of helping your kids get better faster, because we know in conventional pediatrics, when your kids are sick, what's there to do? It's just wait and watch, right? It's supportive care.
Right.
Or if they're sick long enough, you get the antibiotics. So these tools like homeopathy, essential oils, acupressure, herbal medicines can get them, better, faster, and also have the goal of reducing the use of unnecessary antibiotics. Because in some studies, up to 70% of antibiotics are inappropriately prescribed for children. And when there's a list of 6 questions that I recommend all parents ask the prescribing physician before they start antibiotics, right?
Yeah, that's
The
great.
number one question is so simple. It's just asking, hey doc, is this antibiotic really necessary?
To try to tie this to some relevancy for people in our audience who may be viewing podcasts, reading blogs, and you feel you have a just wide array of options, dietary changes, supplements, what can help prioritize which ones you should consider first would be the ones that have better evidence. So just to close that loop for people, it's not that I think any doctor is trying to be dismissive when they look to having higher quality evidence. It's they want to try to give you the highest probability that what you do, what you spend your money on is going to produce a positive result rather than just potentially wasting your money.
So I'll answer that in 2 ways. The first is to say that the most cost-effective thing to do is to remove the substances that may be damaging the gut and causing the leaky gut. And so I think it's important to keep in mind, we had the example of the bile acid supplement, which may be a factor. We know that alcohol ingested can have a deleterious effect on the leaky gut, and non-steroidal anti-inflammatory drugs. And of course, if you have a propensity to develop celiac disease, then gluten in the diet is another factor. So those are the 4 things I always keep in mind when I start consulting with a patient. Let's first of all remove the stuff that may be damaging your GI tract.
Love it.
Okay. Yep. Now, having done that, then I do think that based on the evidence that we have, supplementation of a galacto-oligosaccharide prebiotic, and among the probiotics, the best evidence comes from the study I mentioned before on bifidobacteria species. Those seem to be the agents that have the best benefit. And I mentioned glutamine as well. And in one of those articles which we published, one of our dietitians here at Mayo Clinic kindly helped us by giving us a list of the foods that contained the good substances. Oh, one other thing I forgot to mention was emulsifiers. So Heidi, sort of processed foods also have the types of agents. I'm not a chemist, so I can't tell you more than that. That could be like bile acids, removing the surface mucus and making the intestine more permeable, more leaky. So those are the main things that I would mention.
So a number of threads there to pick up on. I love this conversation. To echo, ultra processed food, something that isn't going to help people with anything really. And we did come across a paper that this was looking at multiple endpoints. I think there was neurodegenerative diseases, gastrointestinal diseases, but they tried to quantify at what level of processed food consumption do you start to see a jump in symptoms. And it was 18%, if I'm remembering correctly. I believe it was 18%. So as long as there's less than 18% of those foods in your diet, you might be okay. Now, I'm not advocating the consumption of ultra processed food, but as someone who sees a lot of people who really care about improving their health, sometimes they develop this sort of orthorexia, this fear of food, because they don't want to eat gluten, dairy, soy, lectins, FODMAPs, salicylates, emulsifiers. And then they end up on the other end of the spectrum, which is they're withdrawing from going out to dinners and their social life. They're underweight. They're not sleeping well. So, a little bit of almost anything is probably okay within reason. And I think that includes alcohol. Probably not something that's going to help anybody. But, if you have a weekly dinner with friends and people are going to have a couple glasses of wine, do you need to shy away from that? Again, if you don't want to drink, you don't have to drink. That's fine. But, I try to be good about leaving that little crack in the door for people so they don't develop sort of food neuroses. What's your perspective on what might be a reasonable level of consumption of processed food, of alcohol?
Yeah, first of all, I completely agree with that point. The last thing we want to do is to get people to shy away from having a reasonable, well-balanced diet and to, benefit. One of the most important things in the cultures that probably you and I both come from is having an enjoyable meal with your friends or with your family. So absolutely, I hesitate to try to give a percentage because I honestly have not studied it and I have not seen it, documented in literature. But the levels that you mentioned make complete sense to me. And I think we need to bring a modicum of common sense to these issues when we make our recommendations on dietary and alcohol intake. And the levels that you mentioned are certainly not worrisome.
Seem reasonable, yeah.
If I do a stool test and I do a sensitivity test, that's always helpful. Caprylic acid is a pretty common, product that comes up very positive for many. The problem with the Horopito, which seems to be an antifungal, but also seems to have some biofilm busting, is that honestly, there's just too many people that it upsets their stomach. It's not the minority. It really almost seems really to be the majority. So I've had to really phase that out, even just on one a day. It's just really upsetting a lot of people's gut, and that's unfortunate. But N-acetylcysteine is actually a fairly decent fungicide, but also has some biofilm busting aspects of it. So I like doing that. Of course, there's oregano, as you said, and garlic and berberine and pau d'arco, and olive leaf comes up as well. There's a product called, I use from Priority One, SIBO Candida Care, that has your rosemary and thyme, which are good essential oils for fungus, also oregano, and then some caprylic acid in it. Combination products. There are many companies that make combination products, and those are all really good to use as well. So, any of these. The problem with undecylenic acid is that, the high dose of, you need around 900 milligrams, a day at least. So it's hard to get that. You're taking a lot of pills if you're just doing with the caprylic acid, maybe 1,000 3 times a day, but that's not that hard. Usually a couple of capsules will get you to 500 or 1,000, and two of those 3 times a day is, I think, an effective dose. So it's just kind of, there's a lot of good variety. If you got a sensitivity testing and can more specifically focus it to that species that they found, that's great. But, the sensitivity testing is, limited in what they measure. And, you really just have to use your experience and what you've seen help patients over the years.
So how about a sample protocol for someone's first month? You'd have them on one of the probiotics. You would have obviously on the diet. How many herbals do you use, and
Well,
what's
I
like a
mean, I'm
general
going to put
dose?
everybody on nystatin. I mean,
Hmm.
that's the
Okay,
key. I'll
that's your
start with
go-to.
nystatin, add in maybe another antifungal like caprylic, with the NAC, say, and the probiotic, right? And the nystatin will be 1,000,000 3 times a day, right? That would be a typical protocol. Nystatin, a supplement for or the Bile Candida care, or caprylic just by itself. Say the
NAC.
probiotic and
Yeah.
the NAC.
Okay. And what percentage, just rough estimate here, would you say this moves a needle for? Is it 50-50? Is it 70% of people?
Yeah, I mean, I would say, 80% of the
Mm,
people, 80 to 90%. If there was as clear as a diagnosis on the iffy people, I think it could be maybe, 50-50. But if I saw it in the stool, their Candida questionnaire was at 300, just
right.
crazy. I'm going to expect around, 90%
Okay.
are feeling
Good.
better for sure.
For the ones that aren't, what do you do second month? You said you may need to go a little bit higher of a dose. So are you just increasing some of the dosages plus, I'm assuming, adding in a few other agents, or how do you handle that second at bat, like I was
Well,
saying earlier?
the second one, I would certainly, so the question is, do I move up to something like itraconazole, one of the azoles, right? I don't really think fluconazole, diflucan, is any better than nystatin, personally. Itraconazole is one of the ones that kills the bud and the hyphae. Um, you can get it really cheap from Cost Plus Drugs, Mark Cuban's pharmacy. It's like 30
Mm,
bucks for a month. It's really cheap.
nice.
But it's a drug, and and of course the azoles may affect the liver. So I will always give liver support with an azole. I will always give a supplement liver support if I'm moving to that product. I would be changing the antifungal supplement, and and then seeing one more month if that could work, if we're going to stay with it, versus moving on and doing some other testing and seeing if, or some other analysis, and just
Right.
seeing, like you said, is there instead something histamine or something else going on that I just misjudged this first month.
When you do use the herbal antibiotics, so to speak, for SIBO, they're also all antifungal. So you can be hitting some of that fungal or candida overgrowth at the same time. However, I do want to say that clinically, I often found when people really did have candida along with SIBO, those typical SIBO antibiotics that are also antifungals, I didn't find them to be antifungal enough. Or somehow it's like they were they were preferentially going to hit the bacteria in the body. And so what I'm talking about is berberine, Allison, oregano, neem. These are all antifungal, but what I found was I would have to add in things that were a little more focused on fungal, like uva ursi or pau d'arco or caprylic acid or undacyclinic acid, to really get the effect we needed.
There was this sulfur protocol that you had mentioned. I think it's a high dose MSM. and helpful, if I'm remembering correctly from our conversation, for bloating, distension, constipation individuals. But would love to hear more about this.
Yeah, so this was from Dr. Janelle, and she presented this at the Gastro A&P conference in the fall of last year, 2023. So this is a wonderful gastroenterology conference for any practitioners listening. It's the Gastroenterology Association of Naturopathic Physicians, our annual conference. It's GI focused only. I love it. It's my favorite conference. And so we had her come. I'm on the planning committee, so I'm also quite biased. I love getting all these wonderful speakers. You're going to be coming in to speak for us. So
Yeah, I'm looking forward to it.
yeah, that's going to be great. So she gave this very fascinating lecture where she explained that she's been using this high dose MSM, high dose sulfur treatment for SIBO patients with a lot of success. And what would be the mechanism here? I don't know. It's a little wishy-washy in my mind. I'm not sure I care, but the mechanisms put forward were that it's antimicrobial. It is for sure, and also that many people have a sulfur deficiency. Correcting that can correct many things. And one of the things sulfur does in the body is it's part of our structural bonds. In our tissues. And so when we can get those tissues strengthened, we might be able to affect motility and the migrating motor complex also, theoretically.
And I mean, MSM is used for joint pain, right?
That's
Traditionally,
right.
as I understand it. Yeah.
So what
So,
she does
makes sense.
is she titrates people up from, anywhere from a pinch to, I don't know, like a half a teaspoon, and then gets them up to the full dose, which is 30 grams, if I'm not mistaken. And I think it's about 2 tablespoons. And then you do that for 2 months, and then step it back down to either being off of it or a maintenance dose of maybe around 2.5 to 5 grams a day. Some people will need that ongoing, others may not. She also does some other things. She removes raw foods, cruciferous and allium vegetables and legumes during that time. And she does warn that die-off can occur because it is antimicrobial. So there are people that deal with that. And then she reintroduces the foods when she goes back down to the maintenance dose. And as you said, she says it works best for the chronic constipated, chronic bloated type of patient who will feel better when they pass gas. That gas comes out like they have fermentative gas accumulation. That's what the bloating is from. And she just shared case after case of success, and we were all really excited about it. So my friend and colleague, and also you've had her on, Dr. Alana Gurovich, she started doing it in clinic with her patients. She really wanted to see how well this was working or would work, and she did it, last I heard, on about maybe 30 patients, and has had very good success. That it worked for most, but not all. And she was focusing it on the chronic constipated, chronic bloating cases. She's now switching over to trying it on diarrhea patients, SIBO patients, and we don't know how that's going to go yet. But basically, the bloating is coming down and the bowel movements are occurring. So for whatever reason, I don't know, but I'm so grateful to Dr. Janelle for sharing this interesting, different, new treatment.
Yeah, this is really cool. And especially with it being validated by, to some extent, Gurovich, right? And in a population of people who are somewhat non-responsive, right? And that's actually one thing that I've tried to make a note about when I'm evaluating a new therapy, to be careful not to only reserve it for the non-responsive patients, because that could give you a false perspective on it. All right, guys. Well, again, I hope this helps. I hope you will comment, and I hope you will share this video with one person you think it can help.